Welcome to part 3 of our series on the basic principles of intraoperative TEE. Today, we are getting into the real heart of the matter, the clinical applications. We're going to explore how this incredible tool helps us tackle two of the most critical tasks in the operating room, performing a comprehensive evaluation of the heart valves and keeping a close eye on myocardial wall motion.
Hello, anesthesiologists interested in TEE. This video presents a training course to help you learn the basics of TEE. Hola, anestesiólogos interesados en la ecografía transesofágica. Este video presenta un curso de capacitación para ayudarles a aprender los fundamentos de la ET. This technology gives us a live, incredibly detailed look inside a beating heart while surgery is happening. That gives us just invaluable information to guide patient care and make those critical split-second decisions when it really counts.
So here's our game plan for today. We're going to kick things off with a really deep dive into valvular evaluation. Then we'll pivot to monitoring for ischemia. After that, we'll quickly touch on pericardial disease, take a little peek into some future technologies, and then wrap it all up with the key takeaways. Sound good? Let's get started.
All right, our first and biggest section gets right to it, the valves. We're going to conduct a really thorough systematic evaluation of the aortic, mitral, and tricuspid valves. We'll be looking at both stenosis, which is a narrowing of the valve, and regurgitation, which is when you've got a leaky valve.
And we're going to start right at the main exit door of the heart, the gateway to the entire systemic circulation, the aortic valve. It's such a common site for problems, and knowing how to properly assess both stenosis and regurgitation here is just non-negotiable for any anesthesiologist who uses TEE.
Let's kick things off with aortic stenosis. Our approach is always twofold. First, we have to visually identify the classic signs, the changes to the valve itself. And second, we use the power of Doppler physics to actually put a number on it, to quantify just how bad the obstruction is.
Okay, now take a look at this. This slide is a perfect example of what I'm talking about. On the left, in the 2D view, you can see all those hallmark features of aortic stenosis. The valve leaflets are obviously thickened, they're bright, or what we call echogenic, and they're just loaded with calcium. You can really see how their movement is restricted. But then, look at the image on the right. The 3D view gives us this incredible surgeon's eye view from the aorta looking down. It's just a fantastic illustration of that narrowed, kind of fish mouth-shaped opening that is so characteristic of severe AS.
So after we see it, we have to measure it. And this table right here is our cheat sheet. We focus on three main Doppler measurements. Just think of it like this. A tighter valve forces blood to speed up, so we get a high aortic jet velocity. If you see a speed over 4 meters per second, that's a big red flag for a severe problem. This high speed also creates a big pressure drop, or mean gradient, across the valve. A gradient over 40 millimeters of mercury is considered severe. And finally, the most direct measure of all is the aortic valve area. A normal valve is around 3 to 4 square centimeters. When that number drops below 1.0, that is the definitive marker for severe aortic stenosis.
Now, one way we can measure that area is with a technique called planimetry. It's pretty straightforward. We get this mid-esophageal short axis view, we freeze the frame right when the valve is at its widest opening, and we literally trace the orifice. As you can see, the machine calculated an area of 0.97 square centimeters, which lands it in that severe category. Now, while this method is super intuitive, there's a catch. Its accuracy can be really hampered by heavy calcification, which can create shadows that make it tough to see the true edge of the opening. So because planimetry can be tricky, our real gold standard for calculating the aortic valve area is the continuity equation. This is just a beautiful example of physics at the bedside. It's all based on a really simple idea. What flows in must flow out. The volume of blood passing through the left ventricular outflow tract, or LVOT, has to equal the volume of blood being squeezed through that narrow aortic valve.
Okay, so how do we actually do this? Let's break it down into 4 simple steps. Step 1, we measure the diameter of the LVOT just before the valve to calculate its area. Step 2, we use pulse wave Doppler right in that same spot to measure something called the velocity time integral, or VTI. It basically tells us how far a column of blood travels with each heartbeat. Step 3, we switch to continuous wave Doppler to measure the VTI of that super fast jet shooting through the stenotic valve itself. And finally, step 4, we plug those 3 numbers into our equation. The aortic valve area is simply the LVOT area times the LVOT VTI, all divided by the aortic valve VTI.
And this is just a perfect illustration of how we gather all that data. On the left, we measure that LVOT diameter. Here it's 1.7 centimeters. Then in the middle and on the right, we get our two Doppler tracings to find our VTIs. The LVOT VTI, using pulsed wave, is 24.8 centimeters, and the VTI across the aortic valve using continuous wave is much higher at 102 centimeters because the blood is accelerating so much. You run these numbers through the equation, and you get an aortic valve area of 0.55 square centimeters, confirming this is definitely severe aortic stenosis.
Okay, so we've covered a valve that won't open properly. Now let's flip the script and talk about the other side of aortic valve disease, regurgitation. This is a valve that won't close properly. Our job here is to spot that backward flow of blood from the aorta back into the left ventricle and, just as importantly, to grade how severe it is.
This table gives us a great summary of all the parameters we can use to quantify aortic regurgitation. And while there are a lot of metrics here, I want you to really focus on two of the most practical and reliable ones we use in the OR. First is the vena contractor width. A width of 0.6 centimeters or more is a really strong sign of severe AR. The second key parameter is the pressure half-time, which we get from Doppler. A really fast drop in pressure, giving you a half-time of less than 200 milliseconds, also tells you the regurgitation is severe.
So what in the world is the vena contracta? Well, the easiest way to think about it is as the neck of the leaky jet, right at the point where it shoots back through the valve. This is an incredibly valuable measurement because it's the narrowest, highest velocity part of the flow, and it directly reflects the size of the actual hole in the valve. If you measure the wider, more turbulent jet further down, you can get fooled. But the vena contracta gives us a much more accurate and reproducible number to work with.
And this slide shows us exactly how we measure that second key parameter I mentioned, the pressure half-time. We use continuous wave Doppler and look at the velocity of that leaky jet throughout diastole. Now with severe AR, the pressures between the aorta and the LV equalize really fast, so the velocity drops like a rock. That gives you a very steep slope on your Doppler graph. But in this example, you can see the slope is really shallow, almost flat. This long pressure half-time, 840 milliseconds, tells us the pressure difference is holding steady, which is exactly what you'd expect to see with mild aortic regurgitation.
Now that we have a solid handle on the aortic valve, let's turn our attention to the left ventricle's inflow valve, the incredibly complex and elegant mitral valve. And just like before, we're going to look at both stenosis and regurgitation, but we'll start with understanding the reason for any leak we find. You see, when we find mitral regurgitation, it's not enough to just say, yep, it's severe. We have to describe why it's leaking. And the Carpentier classification is the universal language we use to do that. It's a functional system that brilliantly organizes MR based on how the leaflets are moving. And this is so important because it directly tells the surgeon what kind of repair strategy they might need to use.
Let's walk through it. Type I is when the leaflets themselves move normally, but the valve still leaks. Think of it like a good door in a warped frame. That's annular dilation. Type 2 is excessive motion, or prolapse. This is where a leaflet billows back into the atrium, often because the little ropes, the chordae, have stretched or snapped. And finally, type 3 is restricted motion. We split this into 3A, where the leaflets are stuck in both systole and diastole, like you see in rheumatic disease, and 3B, where they're only restricted during systole, which is classic for ischemic disease where a bad section of wall is pulling down on the valve.
Now, when it comes to putting a number on mitral regurgitation, one of our most powerful techniques is the PISA method. The physics behind this is really cool. As blood rushes toward that tiny regurgitant hole, it forms these beautiful little concentric domes of equal velocity. By measuring the radius of one of these domes at a speed we choose, we can actually calculate the flow rate and figure out the exact size of the leaky hole and the volume of blood leaking back. It's an absolutely essential tool for getting accurate quantitative data. Okay, let's hop over to the right side of the heart now and talk about the tricuspid valve. While tricuspid stenosis is pretty rare, tricuspid regurgitation, or TR, is actually quite common. A lot of the time, it's what we call a secondary problem. It's the consequence of high pressure or volume on the right side of the heart from other issues, like pulmonary hypertension.
And as we look at how to quantify TR, you'll notice the principles are pretty much the same as what we've been talking about. We can look at the jet area with color Doppler. An area over 10 square centimeters is concerning for severe TR. We can use the PISA method, where a radius greater than 0.9 centimeters suggests severe. And we can measure the vena contractor width. For the tricuspid valve, a width of 0.7 centimeters or more is our cutoff for severe regurgitation.
All right, let's shift gears. We've talked a lot about the heart's plumbing, the valves. Now let's talk about the engine itself, the heart muscle. We're moving into part 2, which is all about using TEE as our watchdog for myocardial ischemia.
This is one of the most powerful things TEE can do in the OR because a change in how the wall moves can be the very first sign that the heart muscle isn't getting enough oxygen.
The most basic technique, and something every single person using TEE has to master, is the direct visual assessment, what we call eyeballing, of regional wall motion. We systematically look at all the different segments of the heart muscle from multiple camera angles, and we ask two simple questions. Is the wall moving inward toward the center like it should? And is it thickening during systole like it should? A new abnormality in any region is a huge flashing red light for acute ischemia.
But this eyeballing has some tricky pitfalls, and the tethering effect is a really important one to know about. Imagine one little segment of the heart muscle is ischemic and not contracting well. The healthy, strong muscle right next to it can actually pull that weak segment along for the ride, making it look like it's moving normally. It's a bit of an optical illusion. This can hide underlying ischemia, and that's why paying close attention to wall thickening is so important. Thickening is a much more reliable sign of active contraction, and it's less affected by this tethering.
Now, to get more objective than just eyeballing, we have some incredible advanced techniques like Doppler tissue imaging and speckle tracking imaging. DTI is like a radar gun. It measures the velocity of the heart muscle itself. It's very sensitive, but it's angle dependent, which means you have to be looking straight at the muscle's line of motion. STI, on the other hand, is newer and, frankly, more robust. It actually tracks the unique speckle pattern in the muscle from one frame to the next, which lets it measure deformation or strain in any direction. It's not dependent on the angle, but it does require a really crystal clear 2D image for the software to work its magic.
Okay, now for a quick but critical topic, assessing the pericardium. In the OR, especially after a cardiac case, being able to quickly spot a pericardial effusion, that's fluid around the heart, and diagnose cardiac tamponade, where that fluid is actually squeezing the heart and preventing it from filling, can be truly life-saving.
As we look toward what's next, it is absolutely clear that three-dimensional imaging is changing the game for TEE. What used to be a series of flat 2D slices is now a dynamic, fully rendered 3D model that we can spin around, slice open, and examine in real time. It gives us an anatomical understanding that was just impossible before.
And the advantages are huge. 3D TE gives us far better quantification of leaky valves. In fact, studies show that 3D measurements of mitral regurgitation match up much better with angiography than 2D methods do. It lets us directly measure the area of the vena contracta, not just its width, which leads to more accurate regurgitant volumes. And as we saw with that aortic stenosis image, it just gives us this amazing intuitive grasp of the valve's anatomy and the shape of any leaky jets.
Whew, we have covered a massive amount of information. So let's take a moment to pull it all together and boil it down to the most important high-yield points that you can start using in your practice right away.
So let's wrap this up. For aortic stenosis, your key tools are peak velocity, mean gradient, and the aortic valve area from the continuity equation. For aortic regurgitation, your best friends are the vena contracted width and pressure half-time. When you're looking at mitral regurgitation, always think using the Carpentier classification to explain why it's leaking. For ischemia, start with your eyes, but always be aware of tethering and use advanced tools for objective data when you can. And finally, get comfortable with 3D imaging because it truly is the future of more accurate valvular assessment.
And with that, we've reached the end of our explainer. I'll leave you with one final question to think about. As this amazing technology continues to get better and better, with things like AI analysis right around the corner, which of these applications do you think will have the biggest impact on your day-to-day practice and, most importantly, on the well-being of your patients? Thank you so much for your time.